For those of you who have joined us already, we'll be starting on time at 12:15. Thanks for coming, and please stand by. We're looking forward to starting shortly. Bless you. Okay, we're going to get started. Welcome everybody to our monthly clinical conversations program. My name is Barry Sarvet, and I'm a child psychiatrist and the medical director for MCPAP. And I just wanted to welcome everyone to our program, which, as you know, takes place on the fourth Tuesday of every month from 12:15 to 1:15. Today, we're delighted to have a program on early childhood mental health. The topic is what pediatricians need to know about infant and early childhood mental health. And we're going to be hearing from Dr. Carolyn Broudy. Before we get started, we just need to go over a few housekeeping issues. The session is going to be recorded, and it's going to be available on the PAP website at www.mcpap.org. So definitely tell your friends and spread the word. There's also a large archive on the site for our previous clinical conversations, so you should feel free to browse that. It's on the website under Archived News and Webinars page under About MCPAP. Our presenter will stop for questions at several points during the presentation. And there's also going to be time saved at the end for discussion. If you have a question or comment, just type the question into the question box at the bottom of your screen. You can click on questions and enter a question, and then we'll go ahead and read it out to our presenter. If you prefer to just speak your question and don't want to type it, then you can raise your hand or just type the question, or just say in the question box that you'd like to be unmuted to ask your question. At the end of the program, you'll get a survey, and we really would appreciate just taking a moment to fill it out, because we're working on trying to improve our program. So before we begin, I want to just tell you a little bit about Dr. Broudy. Dr. Broudy is a board-certified psychiatrist, and she's the director of a program called the Family Connection Center. She received her medical degree and her master's in science from the NYU School of Medicine, and did her psych residency and a fellowship in women's mental health at Columbia. She subsequently did an infant parent mental health fellowship at UMass in Boston, and she also completed a fellowship with the American Psychoanalytic Association. She's taught at the Smith School of Social Work, and she's worked as a consulting psychiatrist for our MCPAP for Moms program. She has many years of experience working with new moms and young children, which inspired her to open her practice called the Family Connection Center as a way of bringing together a team of therapists who could better serve the needs of the entire family during the early years of parenting. And that practice is located in Western Mass in the Amherst, Northampton area. All right, so we're going to turn it over to Dr. Broudy, and thanks for coming, and welcome, Dr. Broudy.
Thank you so much for having me. I'm really happy to be here and have the opportunity to speak to a group of pediatricians. As Barry mentioned, my background is as an adult psychiatrist, which is a bit of an unusual origin for this kind of talk. But I really started by working with caregivers and parents who were suffering. And then only later did I get trained in infant and early childhood mental health. So I bring a lot of that perspective, I think you'll see in the talk, to the interactions, thinking about how best to engage and to talk to and address parents with young children. So I actually went back and forth on the title. I guess it ended up being the second title, but anyway, so the original title was the REL-i Model, Teaching Caregivers How to Co-Regulate Young Children. And then, you know, I broadened it, and then I kind of went back. So I don't think that this is not a comprehensive talk of everything that pediatricians need to know for infant parent mental health. Instead, it focuses on co-regulation. And I'll talk a little bit about why I think that's such a central part of infant parent mental health. So I think I'm probably preaching to the choir here that pediatricians are poised to promote infant and early childhood mental health. The first 5 years of the human lifespan mark a critical time for rapid brain growth and development. And during this time, children are obviously scheduled for multiple well-child visits, making pediatricians often the first and only port of entry for an infant and family into the system of care. You can see this is probably a very familiar immunization schedule where, you know, children come in at least, looks like about 11 times over the course of, you know, 5 or so years, which is actually a pretty good number of opportunities for intervention. If you think about the average number of times people attend therapy, it's the average number of sessions apparently is 1. So at least you have a captive audience here, which really gives you the opportunity to promote, you know, childhood, infant and early childhood mental health. And, you know, the goal here is to kind of, the focus of this talk is going to be less about intervention, which is how, you know, as physicians we're trained to diagnose problems and then treat or refer, and more about a prevention mindset with preventing problems that arise and optimizing well-being and development with positive reinforcement and developmental guidance. So I'm focusing on the concept of co-regulation because what I find is that in my work as a clinician, working with, doing parenting consults and working with parents and young children, that this is a concept I come back to in almost every case. When you find yourself repeating the same thing with almost situation, you know, regardless of whether the presentation is anxiety or autism or constipation or, you know, behavioral problems in preschool, you're always coming back to this fundamental concept because it applies in all cases with young children. So what is co-regulation? Co-regulation is a dynamic bidirectional process in which each partner makes contingent moment-to-moment adjustments to the behaviors of others. So you can see from the pictures, we learn a lot just by looking at the interactions between, you know, the back and forth. It's sort of the dance between infants and caregivers and how they respond to one another and co-create the interaction. So why is co-regulation so important? So basically, you know, co-regulation provides children with the support, the guidance, and the modeling that they need to understand, express, and modulate their thoughts, feelings, and behaviors, which is pretty fundamental to promoting self-regulation, right? And that capacity for self-regulation is crucial in order to thrive, in order to learn, in order to have any kind of frustration tolerance and resolve problems, you know, and do new things. And it also, co-regulation also is known to promote secure attachments, right? It helps children learn who they are and who others are, and has an influence on their, on a lifelong influence on their sense of their relationships and their self-esteem. So it's really pretty fundamental to what's happening in these early years. Just some data that, you know, that self-regulation and secure attachments are, you know, which are associated with co-regulation, are associated with long-term well-being, including increased IQ, improved attention, academic success, better peer relationships, improved mental and physical health long-term. So I'm going to just show you a quick video here of what co-regulation looks like. And probably most of you have seen this first video I'm going to show, which is a video of the still face. And when we're talking about co-regulation, we're really talking about the whole still face. So, you know, the positive play interactions at the beginning, the dysregulation that happens when the mom stops interacting with the child, as you'll see, and then the repair process when she reunites with the child. But what I want you to try to focus on while you watch the video is that repair process. Because that's what, when I say co-regulation, that's what I'm focused on, trying to help parents understand how to do. So see if you can think in your own minds about how would you describe what's happening in those few seconds that she's repairing the rupture? So let me bring that up.
Babies this young are extremely responsive to the emotions and the reactivity and the social interaction that they get from the world around them. This is something that we started studying 30, 40 years ago, when people didn't think that infants could engage in social interaction. In this still face experiment, what the mother did was she sits down and she's playing with her baby, who's about a year of age.
I'm like, girl. Oh.
And she gives a greeting to the baby gives a greeting back to her.
Yeah.
This baby starts pointing at different places in the world, and the mother's trying to engage her and play with her. They're working to coordinate their emotions and their intentions, what they want to do in the world. And that's really what the baby is used to. And then we ask the mother to not respond to the baby. The baby very quickly picks up on this. And then she uses all of her abilities to try and get the mother back. She smiles at the mother. She points because she's used to the mother looking where she points. The baby puts both hands up in front of her and says, "What's happening here?" She makes that screechy sound at the mother, like, "Come on, why aren't we doing this?" Even in this 2 minutes, when they don't get the normal reaction, they react with negative emotions. They turn away. They feel the stress of it. They actually may lose control of their posture because of the stress that they're experiencing.
Okay. I'm here. And what are you doing? Oh, yes. Oh, what a big girl.
It's a little like the good, the bad, and the ugly.
All right. Did that come through okay? Yeah.
It did, yes.
All right, so that's one. Oh, actually, I'm going to show you another video. So that's one video, and we're going to go back. But basically, you know, sorry, I'm going the wrong direction here. That little piece at the, I mean, that whole thing is co-regulation, but that little piece at the end, the little dance she did to engage the baby and get her back to a regulated place is, it took, you know, maybe 3 seconds or something, but it's actually a very complicated relational interaction that can be broken down into steps so that we can try to help caregivers who aren't as successful at doing this to learn how to do it. And that's what this REL-i model is, breaks down those steps. So I'm just going to show you one more video of, it's very quick, of similar kind of co-regulation, but now with a slightly older child. And this is very brief, but just try to think in your own mind, how would you describe what the mother is doing?
Wait. What did I say about it? Let's see. What did I say about it? Let's listen one more time, Kay. I'm going to sit here and I'm going to do all the paperwork. You're not going to touch that cookie.
The cookie the mother is referring to was a snack made available to the child by the staff to be eaten at the end of the filming.
When I get done with this paperwork and I give it to the guy, then you can have the cookie. Okay? I know it's really hard. I know it's really hard. I know it's hard. Come sit by me. Come here. Me being the mom and him being the kid. That's the biggest thing.
All right, so now you can see what we're talking about, but then how do you teach this to a parent who's struggling to do this? And this is what the REL-i model offers. It stands for self-regulation, empathy, limit setting, and intervention. And this is basically, okay, we skipped a slide here, but that's okay. So this is basically a graphic representation of the model. And I found myself drawing this for almost all the parents I worked with, and they all found it quite helpful to know what, you know, was ideally supposed to look like when a child gets dysregulated. So if you can see, there's 3 lines here. The first one on the top here is the child activation, and they're going along in sort of their regular activation state. And then an incident happens. In this last case, it was the little boy saw a cookie, right? And then he gets frustrated and dysregulated, and it gets beyond his sort of normal threshold, and he begins to go into, he didn't actually, she was able to keep him in a pretty regulated place. But in many cases, the child will sort of peak at that point into a state of peak dysregulation and stay there for a while until the parent, who also, as you can see on the second line, the caregiver activation, begins to feel dysregulated, until they're able to self-regulate themselves and then help provide what the child needs to come back to a re-regulated state. And so what I'm going to focus on is what the caregiver is actually doing as they're trying to help get the child back to a re-regulated state. And I've broken it down into these 4 steps. And the 4 steps are not always linear, but they're usually almost all there in some capacity. And the first is self-regulation. So, and this, you know, that the parent has to first be in a calmer, more regulated place themselves if they're going to be able to be effective at all in helping the child calm down. The second is empathy, right? Is showing the child that the parent understands what the child is experiencing. The third is setting limits, so reinforcing that this is what the child can expect. And the last is what I call intervention, or doing something to try to help the child move forward, to get out of this sort of negative space and onto something more rewarding. Now, most parents, most therapists, in fact, start with either setting limits or intervening. What is the behavior we see? What is the behavior we want to stop? How are we going to respond? But the point of this is just to really emphasize that the self-regulation and empathy part are really crucial to helping re-regulate young children before you can get back to, the limits and the behavioral intervention. Okay, so as we go through this, I'm just going to talk about co-regulation and this model. And, this may just be an opportunity to learn more about co-regulation, but I would love to maybe at the end hear some of your thoughts about how could this be integrated into a pediatric setting? Maybe you've already integrated it in some capacity, but this is sort of my thought about, pie in the sky probably, but, could there be a provider in the practice who illustrates, the importance of co-regulation and its components to the parent, helps the caregiver choose a focus component. So, would you like more information about any of these parenting strategies, the self-regulation, empathy, limit setting, or behavioral interventions? Provides them with material on that component to help and explains the process, that the goal is not to get this right every time, but to understand what works for your child, to make a note of what the focus area is in the child's chart and follow up with the caregiver at the next appointment and provide additional support as needed. So how did it go with, setting limits? We talked about this last time. What did you notice worked? So it's really a focus on education, providing information, and having them shift their focus on themselves, what strategy they can choose for themselves to improve on, and finding places where they can be efficacious. So I'm going to go through, and I'm not sure if we're going to have time to go through all of these, but I'm going to go through each of the 4 components. The first one is self-regulation and how to help, caregivers with each of these, in each of these areas. So I think we can all kind of relate to this, how I used to talk to my kid and now how I do talk to my kid. We all get dysregulated, by young children, because we are in effect helping to regulate them. And part of, empathizing with them is actually feeling some of their dysregulation. And there are 2 kinds of ways of thinking about improving caregiver self-regulation. One is thinking about what the caregiver can do in advance. So really reflecting on what are their triggers, having information, where you could give this to the caregiver and it says, what are your triggers? Know what they are. Know what you feel like when you know what to expect when you're dysregulated and what that feels like. And actually helping them visualize what they would want to do in those specific triggered situations can be helpful, rather than what would you say, or what should you do, or this is what you should do. Saying, if you could visualize yourself doing it, what would you do? Because so much, as we'll talk about, so much of what has to be done is not just about the words, but about what they're actually doing with their whole body. And then helping them in the moment to notice, what does it feel like when you're dysregulated? So can you just notice that? And, obviously, can you try in any way that works for you to relax and to, breathe and exhale and release some muscle tension? And then finally, can you become curious and begin to ask the question of, why is my child behaving in this way? So, one of the things I think that we hear over and over again is the way that stress interferes with reason, right? That dysregulation interferes with the caregiver's capacity to empathize and empathize with the child, and that young children, even in fact adults, tend to be unreceptive to reason when they are dysregulated. So we know that in order to connect with the child, we have to have them be in a more organized state. And we know in order to access empathy and reason, we have to be in a more organized state. But I think what I want to stress here is just that the meaning that we make of the child's behavior is one of the primary things that's going to be dysregulating for a caregiver. So if you can help the child, if you can help the caregiver make meaning of the child's behavior in a way that helps to organize them, they're going to become, less dysregulated. So these are just meanings that can be dysregulated. Very commonly, if someone's blaming themselves, if the caregiver is blaming themselves, even sort of in a subconscious way, like this behavior means something bad about me, I'm not doing a good job, I'm being a bad parent. If they're blaming the child, this means something bad about my child, he's a sociopath, what's wrong with her, she's never going to amount to anything. Or if it's a trauma trigger, right? So if any of these are the meanings that caregivers are making of the child's behavior, then it's going to be much more dysregulating. If the meaning is specific to the state of the child, like they're hungry or they're tired, or this is a new situation for them, if it's developmentally appropriate, it has to do with, they really struggle to shift their attention when they're this age. And if it's a more benign interpretation, so trying to project onto the child the most benign interpretation, they are still forming their identity. So they will, if you can project that onto them, they will actually begin to understand themselves and understand their own behavior. So the point of all of that is that the providers can help promote caregiver self-regulation by understanding what meaning the caregiver is making of the child's behavior and assisting them in making more developmentally appropriate, state-specific, benign interpretations. So, the degree to which pediatricians are able to do this, I think it can be time-consuming, but this is just sort of an example of the kind of dialogue one might have about this sort of thing. So the caregiver might say, when he doesn't get what he wants, he has really big tantrums. What should I do? And I don't know how many parents really present like this to you, but I imagine that you get these questions. So you might say, how do you tend to respond? And the caregiver might say, well, I get really angry and I just walk away, for instance. And you could say, you could then wonder, like, what are you thinking when that happens? What is your experience like? So you're wondering about the caregiver's experience. And when I ask people this, I get answers like this all the time, which is like, what am I doing wrong that he gets so angry? So this is an example of the caregiver becoming extremely dysregulated because the meaning of the behavior is, I'm a bad parent, I'm doing something wrong. So you can make a very powerful intervention if you know that, and then you say, you don't have to feel it's your job to prevent him from getting angry. Children have very big feelings, and it's normal for them to get angry when they don't get what they want, but you can begin to help them learn how to cope with these big feelings. So there's a lot of kind of interventions that you can do to just help reframe parents' understanding the child's behavior, which promotes self-regulation and also promotes empathy, which this mother clearly needs help with as well. So there's a lot of overlap with these categories too. That empathy promotes self-regulation. Self-regulation allows for empathy. So what is empathy? The capacity to feel and understand another's internal. I guess I could also just actually pause there for a moment to see if anybody has any specific questions yet.
So there are no questions yet in the question and answer section, but if we see any raised hands or see anyone enter anything, we can get going with a question.
Okay. I'll just keep going then.
Yeah, there's no raised hands either. Okay, go right ahead, Carolyn.
Okay. All right, so empathy is the capacity to feel and understand another's internal experience, right? So this very beginning, I don't know if you can actually see my pointer, but this very beginning stage of the parent's dysregulation or disorganization that happens when the child becomes disorganized is actually part of what empathy is, right? You want to see this because this is how the parent begins to empathize. But if they continue to escalate like the child, they no longer have the capacity to do the second part of what empathy is, which is to understand the child's experience. They then become one with the child's experience and are no longer a container of it or really that helpful to the child. So one thing that can be helpful is just, the kind of, if you could imagine a parent saying, struggling with empathy, you can outline, the common reasons young children become dysregulated, just to help them understand why, what's normal and what's a common trigger. So, here are some common triggers: hunger, feeling tired, feeling bored, needing more independence, wanting more safety, difficulty with transitioning, difficulty with delayed gratification, and jealousy. These are all extremely common and often interpreted or often misinterpreted by caregivers. And if the caregiver can be attuned to what the child's experiences, that can really help regulate the child. So another important part about empathy is that for the most part, it is communicated with young children through nonverbal communication. So a lot of programs that help caregivers learn to empathize say, validate the child's feeling, or, name the child's feeling. But actually, I think when I see that, it's generally parents aren't really helping regulate the child, because in the same way, it's not really helpful when somebody says, you're angry, without any kind of emotional expression or gesture that indicates that they know what the anger feels like. Children need to see the facial expressions, the body gestures, the vocalizations, and the touch, these different nonverbal kind of ways of communicating. And in the same way, parents can begin to or caregivers can begin to understand children better by attuning to their nonverbal gestures. So ways of promoting caregiver empathy: providers can ask and listen. I wonder why she does that. Do you have any clues that you notice in her expression, body language, or tone of voice? And the point here is that you're both modeling reflective thinking and curiosity and providing the caregiver empathy, and also using this as an opportunity to provide developmental guidance, which is that you're helping to focus their attention on the nonverbal cues of the child. So this is Barry Brazelton, who says, to me, the biggest gift I can give to each parent: watch your baby and trust that baby to tell you when you're on the right track and when you're not. And I think it's important that he says watch and not know, or not see even, because what he's saying is that you have to really observe what they are communicating to you in nonverbal ways. Another way providers can promote empathy is to reinforce the positive. So if you see some sort of positive exchange of nonverbal communication in the here and now, in your, in front of you, you can reinforce that. Look how she recognizes your voice. She really knows what mommy sounds like. So you're bringing the parent's attention to what the child is experiencing. Did you notice how he looked away for a moment, and then when he was ready, he looked back at us, ready to engage again? That's a really good sign he's developing capacity for self-regulation, right? So sometimes when infants look away from caregivers, they interpret that as rejection. And here you're giving them a different frame for what's happening, that this is his, look at how well he's developing this capacity to self-regulate. You're so gentle with her, she really responds to your touch. So you're just focusing on the nonverbal. And then this is, I think, what I've already said, which is promoting empathy by providing empathy and modeling curiosity and reflection. And I think sometimes pediatricians, we're supposed to be the, doctors are supposed to be the experts, and you can give a lot of expert opinions, but I think it can also be very helpful to just model humility and this way of thinking and this way of having to go through and figure out what the child is telling us by watching them, saying something like, it can be so hard to know why children do what they do when they cannot tell us. You know, we wonder and we make our best guess about what might be motivating their behavior, but often we only know if they're right, if we're right, based on how they respond. And sometimes it can take a while to figure it out. So I think it can be really reassuring when parents feel frustrated that it is a process of learning what your child's trying to communicate. All right, so we've talked about self-regulation and empathy. And now we're going to talk about setting limits. And again, you know, I think of this from the perspective of the infant and the young child, but also from the caregiver, you know, so why might parents struggle to set limits? I mean, we can all relate to the surrendered mom. We've all had our moments, right? And, you know, part of it is that I think one reason that caregivers can have difficulty setting limits is that they worry about doing it. They worry that they're going to be mean. They worry that it's going to be, there's going to create conflict, or they don't really understand why they need limits. So I think just being able to explain in a very specific way why limits are important, you know, that limits are important because they help the child know what to expect. You know, when life is unpredictable, it can make kids feel anxious and out of control. And when they know what to expect, they feel more secure. I think that can feel very reassuring to caregivers that you're not hurting your child, that you're actually making life more predictable, which helps them feel more secure. And then the other reason why I think caregivers struggle is because of a lack of, you know, limited resources, emotional or physical, that it's just exhausting to set limits constantly. And so, you know, if that seems to be what's going on, helping caregivers realize that a lot of the limits can be set ahead of time or afterwards when you are in a more resourceful state, you know. So this is, I mean, this is, you know, this is talking about setting up rules so that you don't have to say the same rule every single time, setting up schedules, having guidance so that when you're in the car on the way to supermarket, you say, you know, we're not going to be eating any candy at the supermarket, rather than waiting till you're in the moment of the child getting upset and then having to bring them back down, you know, so preventative rule setting or limit setting. And then also the delayed repair, which is you don't have to find the solution to this, you know, this problem right now. You can wait until you're all in a more organized, you know, calmer place in order to figure out how you're going to prevent this next time. So, okay, so that's, I don't know how much you are seeing this, but I do think that I see all the time couples coming to me and sort of splitting the difference here. There's a tug of war where one of the caregivers empathizes and the other caregiver tends to set the limits, and they split this. And I find that it can be extremely helpful and a powerful intervention to just explain that children need both. They need limits and they also need empathy, and that both parents are offering something important. And then finally, we'll talk about intervening. We think this child needs more. So behavioral interventions, again, you know, a lot of people, this is where they start. I think of behavioral interventions as slightly different from, I think, what is normally thought of as a behavioral intervention. I think of it as the process of easing children towards a more positive and rewarding endeavor by helping them let go of negative feelings and move on. So behavioral interventions are, you know, not for heavy lifting. They aren't going to solve the problem. They're the icing on the cake. They're what helps the child move forward and gain some perspective and you know, be able to move into more rewarding pursuits. So what's a behavioral intervention look like? Focusing on something positive or funny. So if you think about the mom in the still face, I don't know what you noticed her doing, but I'm not sure if I have the time to go back and show you the specifics of it. But what she initially does is that I'm going to show you because I think it'll be more interesting to actually be able to see it. I'm just going to show this last little part of the repair. So
that they're experiencing.
So you'll notice what she's doing in the repair here. Okay, so the first thing she's doing, probably the first thing she's doing, which we don't see, is that she's doing a lot of internal self-regulation, because it's probably very difficult for her to stay there and you know, watch her baby in distress. The second thing she's doing, as you can see here, is that she's empathizing with her tone of voice and with her gestures and with her touch. And that was very brief. So sometimes empathy is very, very brief, and all of these components are very brief. Right? And now she's trying to move the child out of that state into their usual place of more positive interaction. And see how she kind of goes down there? And the baby and her are both down. So she's doing more empathy again. And now the baby responds.
Oh, yes.
And now they're back. So, so that the behavioral intervention part is really just her kind of trying to move the child into a more positive place by smiling and playing little games. But she's doing it in a very empathic way so that the child responds. If she had just simply gone in there and said, everything's okay, and tried to make things better and more positive without doing that empathy part, the child would have, you know, it's unlikely they would have responded. So the same is true here, where you can see this mom, right?
Was a snack made available to the child by the staff to be eaten at the end of the filming?
When I get done with this paperwork.
So you can see here, she's obviously being very clear in what he can expect and setting the limits very clearly.
And I give it to the guy. Then you can have the cookie. Okay?
So you can see he's kind of beginning to lose postural control. This is a very clear limit, but it's not enough to regulate him.
I know it's really hard.
And mom gets it, and she immediately goes into empathy.
I know it's really hard. I know it's hard.
And then he responds, and he goes from a place of sort of wanting to be in conflict with her to being in a more vulnerable place and showing his sadness. And
come sit by me, come here.
And that's her behavioral intervention. What can we do to help solve this and make it a little bit easier for you to get out of this place? Come sit by me.
Me being the mom.
So that's what I am referring to when I talk about the behavioral intervention, that it's just that little last part there where you say, all right, come on, you know, let's think about what we're going to do a little bit later, but that you have to do that, you know, or let me count for you to make the transition a little easier. Or what, you know, depending on the age of the child, what do you think we should do about this? You know, maybe engaging them in problem solving, somehow giving them perspective and helping ease them into a more, you know, back into a more positive place. So one thing that you'll notice is that people who have trouble with this part of it, you know, it's often a sign that you're dealing with a depressed or really struggling caregiver, because if in the still phase, what they found is that in the first part where the mom and the child are playing, that with depressed mothers, it looks basically the same. And obviously when they're doing the still phase, it looks the same. But in the repair process, the non-depressed mother tends to have more positive affect, and the depressed mother tends to have more negative affect. So the depressed mother has more difficulty herself recovering from negative affect to positive affect. And so, you know, if you see this as the issue, then it's often a clue that that's what's happening, that they're staying kind of in the depressive affect and not able, and the caregiver's not able to help the child get out of it. So the good news with this model, and that you can, tell caregivers that is that, and I'm sure you've all heard of this, that you only need to get it right 30% of the time. So, the REL-i model looks very linear. You do this, and then you do this, and you do this. But as I said, it's a lot of going back and forth. It's quite messy. And the point of it is that it's really a process of trial and error, like what tends to work. And this 30% statistic is about, how many times parents and kids, young children are mismatched, and how much of the time is matched. And they find that, when they're interacting, only 30% of the time are they matched. And I guess the meaning that people make of this data is that it's actually so important to have those mismatches and to not get it right, and to work through that process of trying to figure out how to get back connected. So putting it all together, as I said, these moments of co-regulation can be microseconds. They can take hours. These are just some everyday examples of how, if you put these components together, it might sound or it might look. There's this is sort of what a caregiver might say. Of course you want that lollipop. I know, it looks so good, but we're not going to have candy now, and you can have something yummy after dinner. So it's a very kind of simple idea, but you're really breaking it down for caregivers so they understand that these are the components that the child needs to be empathized with before they can accept the limit, and that you need to then help them move on to a more positive place. Or, I know you love playing with that toy car, but we need to get ready for school. Can you show me your toothbrush? Something like that. So again, putting it all together, sometimes co-regulation happens in microseconds, sometimes it can take half an hour or more. Not all the components necessarily need to happen every time. Not all the components are equally as important for every child. Often co-regulation is non-linear. Caregivers go back and forth between the steps and not in only one direction. So in summary, the REL-i model offers a preventative model of care that optimizes child development by providing developmental guidance, promoting reflection, and increasing the caregiver's sense of self-efficacy and external support. So I hope that this is a helpful, kind of simplified way of keeping in mind what can be helpful to talk to caregivers about who are struggling with co-regulation, and just to emphasize for them how important this is for young children in order to develop those capacities to regulate themselves and to feel, trusting in their relationships and develop self-esteem. So I think that's about it for now. If you have any more, obviously if there are any questions now, and also if you're interested in learning more, please don't hesitate to contact me at this, in my email here.
Wonderful. Thank you so much, Dr. Broudy. So we have some time. So we have up to 15 minutes to take questions. I do not see any raised hands or questions in the box. So definitely please feel free to enter something if you have a question. Maybe I'll get it started, Carolyn, if you don't mind.
Sure.
I wonder if you could talk a little bit about, for pediatricians, how they can go about finding a provider, who could do this kind of work, particularly if they're not in Western Mass, or if they, if they don't have access to, your group.
Right.
So
Yeah, I mean, I think that this is like a great question, and I think this is what I'm really wondering about. I mean, I think, just in terms of resources, Mass AIM, AIM, stands for the Massachusetts Infant Mental Health Association, and they have a list. I'm not sure if it's posted yet. They may be still in the process of creating it, but I think it might be posted, of all of the infant parent mental health kinds of resources available in Massachusetts. So I think that would be a very useful place to look if you're thinking about referring people out. And then my question really to all of you is, how have you found a way to be able to integrate this, and what do you think about the possibility of integrating it? You know, whether and I don't really know exactly how that would look. I mean, I have a lot of kind of fantasies about how it could happen. You know, I mean, one possibility is to have like a sort of dedicated provider who is working with families and in this kind of way, or a social worker, or, you know, some sort of therapist integrated into the practice, who can check in with families and then, you know, I mean, I think it's about reimbursement, really, you know, and how do you get reimbursed for that time? Can you, but I think that what I tend to find is that there's very, very few parents who have young children or infants and don't have development, social, emotional questions. Just because there's so much to know. And so, you know, what does that look like? I mean, could a social worker, you know, offer their services to each patient who's coming in? And if the parents or the caregivers do have a question, that could be, you know, a family therapy session on the spot. I mean, I think it's right. It depends on what the practice looks like and what the rooms are available, and how to really integrate this stuff. I think it's a great question. I would love to hear from you. I mean, my other idea that I've been thinking about a lot lately is, what if you could put some of this information into videos, so that, you know, in between when the nurse comes in and takes the blood pressure and weighs and everything, and when the pediatrician comes in, which is often, you know, at least 10 minutes, there could be videos providing developmental guidance to caregivers, and then that may help provoke some questions that they could then, you know, ask the pediatrician, and then the pediatrician could help direct them more specifically.
Yeah,
yeah. But I would love to hear your thoughts, and everybody.
Well, so definitely we're very eager to hear questions from the audience, or comments about this. You know, I think it is a challenge, and I can speak from the MCPAP perspective, to say that you know, more and more practices these days, I believe it's in the 40 to 50% range in Massachusetts, have an embedded clinician, at least one, and sometimes more depending on the practice. So there is an increasing kind of prevalence of people having a clinician, you know, at the ready in the practice. And I think relatively few of these practices are, a few of these therapists are early childhood mental health clinicians, but I think some of them are. And I believe that if a practice has an embedded clinician who has experience with early childhood mental health, that they could do some of this work in the primary care setting.
Absolutely.
But I think that generally MCPAP, you know, frequently, you know, finds and helps to find resources for early childhood mental health, and it varies a lot by, you know, community, and, you know, the hubs have different kinds of you know, assets surrounding them, and so in Western Mass, you know, we do have access to a relatively limited pool of early childhood mental health therapists. They're not doing, you know, this model, but I think that many of the evidence-based, you know, psychotherapy models, like Triple P, Incredible Years, and things like that, that's a relatively, you know, not common, but it's you can find people to care for parents and children, you know, and to teach them about parenting skills through those models, which I think incorporates some of the elements of this. I wonder, Carolyn, are there training sites, you know, that, you know, if people do have embedded therapists, that they can direct their embedded clinicians to, you know, teach them to do kind of brief intervention, you know, on the basis of this model in their practice?
Yeah, absolutely. I mean, contact me about that. I'm going to be putting on, I have different trainings coming up, and you know, I do these trainings for school teachers, for, you know, caregivers, and for clinicians. So absolutely, that the info at the Family Connection Center, they can contact me, and I can, I'm happy to talk to people about doing trainings for therapists in pediatric settings.
Great, that's wonderful. You know, there is another question that occurred to me that you know, comes up frequently, you know, in the primary care setting is you know, that pediatricians commonly, you know, do anticipatory guidance counseling with parents who are struggling with, you know, managing, you know, behavioral, you know, and temperamental, you know, issues, you know, for kids. But they're also dealing with kids who have, who are getting younger and younger, who appear to have, you know, more really severe kind of constitutional mental health issues, like, you know, really, you know, like post-traumatic stress disorder that, you know, expresses itself in early childhood, associated with lots of, you know, emotional dysregulation and then you see, you know, early, you know, and relatively severe, you know, cases of ADHD, younger and younger, you know, and it's extremely challenging. So it goes well beyond the kinds of kind of temperament driven
Oh
problems.
yeah, absolutely, yeah.
And then even, you know, not that we kind of are inclined to, you know, throw the book at people, you know, in terms of bipolar disorder, but we see kids who are at risk for bipolar disorder, you know, with bipolar parents or family histories of bipolar disorder in the very, very early ages, you know, where they have, you know, more severe dysregulation than you would normally see. And so sometimes, you know, we're, you know, providing medication treatment for these kids after they've been given a trial of psychosocial treatment. But I wonder if you have any recommendations or thoughts about how to apply some of these principles with some of the, you know, the more severe behavioral disorders that patients are seeing these days.
You know, I mean, I think two things about that. One is that, you know, those kids are going to need, and those parents are going to need a lot more support than, you know, just this. But I do think that this, you know, they're usually going to need, you know, maybe OT and speech and like, you know, interventions at home possibly, and interventions at even, you know, the preschool possibly, if the, you know, depending on where they are. But I do think that this is a helpful way of thinking about it because, you know, basically what determines, you know, the child's capacity for self-regulation and even for, you know, attachment is constitutional and is relational. I mean, there, you know, that both of these things are informing development. And so, you know, I think it can give parents a sense of, you know, like, yes, you're not going to be able to cure his autism. You're not going to be able to cure the ADHD or the bipolar, but this is what you can do. You know, you can help him with this struggle, you know, and these are the ways that you can help him learn, you know, over time. And it can be a very slow process. And obviously there can be a lot of other interventions that are needed. But I do think, you know, even for, it just takes a lot more work, you know, you have to refer those parents out to somebody who can do this work with them more consistently. My hope is that, and I don't know how realistic this is, but that, you know, this model, I mean, it has 4 components. And I think that, you know, okay, so you know, somebody in the pediatrician's office is not going to be able to use this and change, you know, what's going on in a very severe, difficult case of PTSD or whatever. I mean, but could it be, you know, there are so many ways where things go wrong because, you know, of the lack of information and just doing the wrong thing over and over again. And just that, you know, that ounce of prevention are the ways in which you could, because, you know, you could just add a little bit of this in with those parents who aren't so severe, but could really benefit from this, you know, from just learning a little bit about development.
I think that makes good sense, and I think that rings true for me. I feel like this model, you know, is it can be complementary to, you know, other elements of a treatment plan. So some of these more, constitutionally, impaired young children, they can benefit from, a comprehensive treatment plan that has, OT and speech therapy and other kinds of programmatic, behavioral, treatments, and this can still be really useful as a complement to those things,
Right.
as well as medications. Looks like we have a comment from one of the attendees who wanted to just mention, as a comment that there's a program called Healthy Steps. That's a unique program for integrating kind of behavioral health promotion in early childhood social emotional development. So I just wanted to pass that along. I don't know if you have any thoughts about that.
I have seen it, and it looks like there's, a lot of material. I don't know how pediatricians feel about it. I would be really interested to hear how their experience of using it has been, or if they have used it at all.
Yeah, I don't know. I have not heard of too many experiences that would give me kind of a sense of the trend, but it's definitely good to keep in mind. So I don't see any other questions. I guess we'll give a last call for questions. We'll be ending momentarily, but if people have any last questions, they could raise their hand or type something really quickly. All right, looks like no takers. So Dr. Broudy, thank you so much. We really enjoyed your presentation, and people will be able to look at the slides if they go online or pass this along to their colleagues. And otherwise, we'll be looking forward to our next clinical conversation next month, and we're trying to put together the final plans for that, but we're pretty sure it's going to be on the topic of the mental health treatment for children with developmental disabilities, not just autism, but kids with different kinds of cognitive developmental disabilities. And so we'll have more information about that shortly. And thank you everyone for attending, and thank you again to our speaker, Dr. Broudy.
Thank you, Barry. Thanks, everyone.